present a case report of rehabilitation and return to play for a collegiate baseball player that suffered a type 2 SLAP lesion. So just to start out as an introduction about what SLAP is, it stands for superior labrum anterior posterior, and research has shown that the superior glenoid lesions account for about 9 to 10% of all shoulder pathologies. Type 2, which we'll talk about in the case, is the most common SLAP lesion and includes tearing the labrum along with partial detachment or complete detachment of the long head of the biceps tendon. And that can be seen here where the biceps tendon inserts. And then this is the bone right here. And I'll talk a little bit more about that. So there's the bony makeup is basically the scapula, the clavicle, and the humerus. The main joints that are important in the shoulder motion is the AC joint, the SC joint, and the glenohumeral joint. The glenohumeral joint is the most mobile but also unstable joint in the body. It's a ball and socket joint, and it basically allows it to the shoulder to move in circumduction, adduction, abduction, horizontal adduction, abduction, flexion, extension, external and internal rotation. I won't go too in depth about the ligaments, but the ligaments basically function to stabilize the shoulder and basically maintain that structural integrity. The big ones to talk about would be the acromioclavicular ligament, the SC as well, and then the superior, middle, and inferior glenohumeral ligament, which can be seen in these pictures here. And these are kind of an overview. There's also coracoid ligaments. So going into the glenoid labrum, it's a hyaline cartilaginous tissue that is loosely attached to the glenoid. It provides smooth movement of the glenohumeral joint and acts as a buffer between the humerus and the glenoid fossa. So it's kind of similar to the meniscus in function, like the meniscus is mini. So the biceps tendon also inserts into the superior portion, which can be seen at the top of that picture there. And the importance of the labrum is with the head of the humerus, without it, would jam, catch, chip against the glenoid fossa with really any movement. And so it facilitates that smooth movement, and it's important in the ADLs, functional activity, range of motion, and then especially in this case with a basal player with proper throwing mechanics. A damaged labrum could cause catching, pain, inflammation, and other associated pathologies like rotator cuff, and then chondromalacia and laxity. So the muscles, obviously a lot of muscles that act on the shoulder. The big ones to focus on are the rotator cuff. So as a unit, they stabilize the shoulder and they basically hold the humeral head in the glenoid cavity. And then they work to internally and externally rotate the shoulder, adduct and abduct. And those are the supraspinatus, infraspinatus, teres minor, and the subscap. Just briefly going over biomechanics, these are the phases of the throw, which go from early cocking, late cocking, acceleration, deceleration, and follow through. So for a position player, this is a normal throwing motion. Obviously for a pitcher, they would have additional wind-up things, but we won't need to talk about that. So the overhead throw, the main motions that are going through is trunk flexion, lateral flexion, and trunk rotation, along with all shoulder movements, and then the elbow and wrist flexion and extension. So as they throw through the zone, the shoulder rotates into abduction and horizontal abduction, internal rotation, and then into internal rotation with external rotation of the elbow, which causes that torque and that force. So in the cocking phases, that's actually when most force is on the anterior superior portion of the shoulder. And in situations where chronic cases of labral lesions, usually it's due to a peel back mechanism, which is when in that phase the bicep rotates posteriorly and then the labrum shifts over the glenoid, which causes a lesion in it. The case is more of an acute situation, so we won't talk too much about those mechanics, but as the arm rapidly accelerates, it moves to the zone and the scapula protract, and then the shoulder acts as kind of a whip as the trunk rotates and flexes. So going into the case report, 20-year-old and right-handed third baseman, we'll call him John Doe. He suffered a type 2 SLAP lesion during practice. So there was no athletic trainer present. And so he actually continued to play and then presented the next day in the TC. So everything was evaluated in the treatment center the next day, and we found out what happened. But his chief complaints were deep and vague pain in the anterior superior shoulder, and then he also had discomfort in catching with certain overhead motions. So he had a brief history of some biceps tendonitis, but it was pretty inconsistent. He would just go in, go to treatment center and receive like electrical stimulation, stretching, Graston, heat just to manage it. But as he explained the situation, he dove for a line drive as he was in this position, and then braced with his throwing or off so he caught the ball, but braced with his throwing shoulder against that. And it ended up being an impact force with 105 degrees shoulder flexion, horizontal abduction at 30 degrees, and slight external rotation. And this basically caused the humerus to jam up into the glenoid fossa. And then as the biceps was or all the muscles were working to decelerate the arm and working eccentrically, this caused the acute trauma. So you can see in this dive, this wasn't an injury, but if you were to brace in that motion and promptly, that's what caused the injury. So he was evaluated by ATC, and upon inspection, he had no visible swelling, deformities, or discoloration. He had no neurological symptoms, and his active range of motion was normal, but he had dull pain in the anterior superior shoulder, especially with shoulder flexion above the head, external rotation at 90 degrees, abduction, so through the full range, and then horizontal abduction past 100 degrees. His passive range of motion caused sharp pain in the anterior superior shoulder, especially with shoulder extension was a big one when the biceps tendon was on full stretch, and then he felt pain deep to the biceps organ as well. And then through external interrotation, 90 degrees abduction, he had pain through the full range of passive. The ADC then administered special tests. So this included near impingement test, which was negative, but he just had discomfort just because of the overhead motion. And then the clunk or compression rotation test was performed, and this is that top picture right up there, where they're actually rotate and abducted passively. And then that was positive for a lot of pain, but he didn't have any catching with that. And then the big one was for O'Brien's test, which was a big one. He had 8 out of 10 pain, especially in that pronate internal rotated motion, and then was relieved with supination and external rotation when the pressure was released. And that is indicative, according to research, for a SLAP lesion, and it's shown that that test is 100% sensitive and 95% specific for the labral pathology. The ATC also administered other special tests to rule out rotator cuff, brachial plexus stretch tests, so drop arm, Hopkins-Kennedy, and TCAM, to rule out any other pathologies. They also did manual muscle testing just to see where he was at. He actually received a grade 5 or normal for most of the muscles acting on the shoulder, which are these right here. But he was experiencing pain, about 5 out of 10, in the anterior superior shoulder with the elbow flexors. So the biceps brachii, brachialis, and brachioradialis, so they gave him a grade 4 just because he couldn't hold against full resistance. So because of the positive O'Brien's test, clunk test, the Fuchs mechanism, which is common for acute lesions, and then the apprehension he had with shoulder extension, the ATC gave a prognosis of a superior labral lesion with a possible biceps anchored pathology, and they referred him to the team physician. He had an MRI done, which shown here, diagnosed a type 2 SLAP lesion, so you can see that the labrum is torn right here and pulled away as the biceps tendon is also partially detached. So they then had to decide if they wanted to do conservative or surgical treatment. The team physician recommended surgery because, as research showed, conservative management of SLAP lesions is often unsuccessful in current active athletes, especially when there's a component of glenohumeral joint instability. So since there was partial detachment of the biceps anchor, the physician recommended surgery to prevent the re-injury in that detachment. And the surgery occurred about a week later. In the meantime, they wanted to decrease pain and inflammation. So this consisted of mostly ice, NSAIDs, and IFC. He iced multiple times per day, as well as taking NSAIDs, and then IFC whenever he could get into the treatment center, which was usually once or twice a day. So they also did some stabilization of the scapula and surrounding musculature. And then they kind of included some closed chain exercise such as wall ABCs, and then also scapular retractions and protractions, but without weight. This picture was just to demonstrate the motion. And then he also did some pendulum exercises to work on some just light range of motion to keep the shoulder going. So when he had surgery, they went with a arthroscopy that's pretty typical now for a SLAP lesion. So this will just be brief, but based on research, it has a 97% success rate with suture anchors. And so that's what they did. The first picture shows basically the diagnosis of the SLAP lesion. and then the partial detachment of the biceps tendon. That top right picture is showing how they prepare the superior glenoid rim, and they debride the surface to initiate that healing area. And then this one is a suture passage with debridement of the frayed tissue, and then the last one shows the suture anchors, which fixated the biceps anchor and the lesion together. So the fixation was successful, and he began rehabilitation. I'll briefly go through these, mostly over the goals, criteria, and progression, because it was a lengthy rehab process. It took just over 6 months. And with phase 1, the goals were to protect the anatomic repair, prevent negative effects of immobilization, promote dynamic stability, decrease pain, inflammation, and moderate scar healing. So he wore the sling pretty much consistently, except when during treatment or during like when he was showering, stuff like that, and then slept in an immobilizer for the first 4 weeks. So just a quick breakdown of phase 1. He did rehabilitation 3 times a week. He also maintained cardio through doing either stationary bike or walking with the sling. And then he also started a core and stability program just to maintain that throughout. And then he added some arm variations throughout the rehab as he gained range of motion. So this continued throughout it. The range of motion was pretty easy at first with elbow, wrist, and hand. Then he progressed more to some active assistive, and passive range of motion later on, as you can see through the end of the weeks. He received ice and IFC pretty much every day, and then sometimes ice multiple times a day. And then he discontinued the use of the sling indoors at about week 3 and the mobilizer at week 4. Indoors meaning he could do desk activities but would still wear it in public places and doing other things. For scar healing, they did effleurage and laser treatment, basically to moderate it and encourage healing of the scar. And then he also began supine PNF near the end of phase 1. So into phase 2, the goals were to gradually restore full range of motion by week 10, preserve the integrity of the surgical repair and discontinue use of the sling, and then restore muscular strength and balance. And that was at grade 3. So those were the goals, and then he began to do some jogging by week 10, still not using his arms a lot until the jogging began, but then progressive strengthening into more open kinetic exercises, and passive and active range of motion were at no limits by week 8. He rejoined the team with lower extremity lifting or any lifting that was not stressing his shoulder, so certain lower lifts he couldn't do. And then began the Thrower 7 program by week 9, which basically strengthening all range of the shoulder. And then also began posterior joint mobs by week 10 to increase or to help with pain and then increase some mobility. By week 12, he met the criteria to enter phase 3, which included full non-painful range of motion, stability, and no pain, and grade 4 manual muscle testing. Rehab for phase 2, the goals were to establish and maintain full range of motion, improve muscular strength, power endurance, gradually initiate functional and sport-specific activities, and begin the thrower's progression by week 16. So cardio included walking, running, swimming, and he also began sport-specific conditioning with the team, which included some agilities and anything that they were doing in practice that wouldn't stress the shoulder, that he could condition. He progressed stretching and started doing capsular stretches such as against a wall, and then also did posterior glides 3 to 4 for joint mobs. His ADLs were within normal limits in this phase, and then at weeks 13 he began some functional and sport-specific training. This included plyometrics, which were mainly with med balls or weighted balls. And so you can see in this picture here, he did some like rotation and hitting throws. He also did some wood choppers, and then these are weighted external rotation D-cell throws, which are when he's tossing back with that. And then he also began thrower's progression by week 16. He started doing wrist tosses before that with a tennis ball and then a baseball and one arm hitting with a light bat. So going into the thrower's progression real quick, I won't go through all of it, but each step was about a week. And if he received pain, he would stop and repeat the step. He would stop and rest for a day, then repeat that step again. If he received it again, he would stop for 2 days. But he actually went through thrower's progression without any setbacks and followed it pretty closely. Basically, the progression went from increasing distance to increasing speed of the throw and increasing the number of throws. He did phase 3 through step 4, and then phase 4, the criteria was full non-painful range of motion, no pain or tenderness, static stability with isometric holds, and manual muscle testing grades 4 and 5. His goals were to progress strength and progress the throwers program with manual muscle testing grade 5. His strength progressed to 80% of the uninjured side. He continued the Plyos core programs and increased resistance training, and he returned to team lifting within pain limits, which excluded the power clean with really any explosive motion that was landing on his shoulder, and then back squats where that anterior supinated shoulder was in a vulnerable position. He also went through Thrower's progression steps 5 through 8, which were here, was just increasing distance. He started doing some mid-outfield, just lobs to home, and then increased speed as he got through week 24, 3/4 to full speed. And this was repeated for 7 days of each step. So he's began functional training for return to play, which included 5 accurate full speed throws from third base at several different positions with a radar gun measuring the speed of his pre-injury speed, and then dives, both defensive, feet first, diving slides, and then hitting 25 pitches off the machine. And he maintained grade 5 strength and mobility post. But basically, so in conclusion, he returned to play by week 26 with full range of motion, strength, and stability. And this was important in showing that the rehab was successful with fixation of the labral lesion and the biceps tendon. He was able to maintain the structural integrity of the shoulder. So any questions? Yeah.
Does the labrum have a lot of blood flow to it? Does it heal on its own after
The superior portion, which was in the slap lesion, has less vascular flow, but it does kind of similar to the meniscus, often require repair. But if it's a posterior lesion, it tends to have more vascular and more blood flow, so it's more likely to have conservative treatment. But for that superior anterior portion, there's less vascular.
And so does that heal on its own with the sutures, or does
With
it
the
just
suture
basically?
anchors, yeah, the suture anchors were bioabsorbable, so they didn't need their removal. But yeah, as long as it's fixated, it's able to heal on its own.
Do they ever just cut out the broken piece?
Yeah, so they take out with debridement, basically the frayed tissue. But with like what he had, which was partial tendon, they couldn't take it out because it's attached to the biceps, so they actually take that lesion together. If it was something like a bucket handle tear, which is like a type 1, I believe, or type 3, then they would possibly just take that part out, kind of like that next one. So. Any questions?
Phase 1, did you do anything besides ice and Easton for pain management?
Pain management he took. Basically, he iced multiple times per day, but the Easton was the main thing for pain. He began some joint mobs later in the phase.